It's my great pleasure to introduce Dr. Lynn Marie Trotti, who is the Associate Professor of Neurology at Emory University. Clinically, her sleep medicine practice is focused on treatment of people with hypersomnolence disorders and the multidisciplinary care of people with Parkinson's disease. Her research work focuses on the pathophysiology and treatment of central disorders of hypersomnolence through clinical trials, imaging studies, and other clinical studies. She is a member of the Hypersomnia Foundation's Medical Advisory Board, having served as its chair from 2014 to 2020. Thank you, Dr. Trotti.
Hello. Hello. Is that even on? Yes. Excellent. Wonderful. Hi, everybody. So we were brainstorming what I should talk about at this conference, the HF leadership and myself. And they thought it was really important that I go after another video that made people cry, because apparently this is my cherished time slot at these conferences. But really wanted to talk around this idea of misconceptions people have about IH, the unhelpful advice that people get about IH. And, you know, nobody in this room needs me to tell you the terrible things people say, either meaning to be helpful or not. But I thought what I might do is kind of dig into some of those suggestions that you get and think about what's the evidence, what's the data that these things are or are not helpful or true. So that's what I'm going to do with our time today. So many of you probably saw this on whatever form of social media you are on. This was a question that was put out with the intention of getting some data for this conversation today, really just to sort of understand what are the things that people are hearing, particularly when people say things about what you should do. What are those insensitive or unhelpful things that are sometimes coming across? I read through a compilation of this advice, and while I will say it was not at all surprising, because I hear that people hear these things all the time, it was pretty disheartening. I think the messages that you get as a person with chronic disease generally, and as a person with IH or narcolepsy or Klein-Levin specifically, can be pretty hurtful, whether intentionally or not. But thank you for anyone who contributed to that effort by bringing up some of that advice. And the things that I talk about today are basically from that list. So I'm going to try for each bit of advice that we talk about today to give it a score of just flat out wrong. People shouldn't say it, it's just not true. Or it's complicated, meaning maybe there's a grain of truth in there, but it's not as simple as it seems. Or 3, ask me again later. Maybe there's a grain of truth in there. Maybe someday we will realize that was good or bad advice, but we just don't know yet. And I broke down the themes that came from those social media posts really into 2 big buckets. The first is, you are this way because whatever. And the second is, you just need to whatever. So here we go. So I'm going to start with just a couple of, you are this way because. Obviously not pointing this in the right place to advance the slides. So really, I'm not going to talk about laziness because you heard about this from the laziness expert earlier today. I just wanted to sort of shout this out because I think this is probably one of the most, if not the most, damaging messages that people get either explicitly or implicitly when they have a chronic disease, and specifically when it's a chronic disease about sleepiness. None of this is a laziness problem. That's just not, that's just a lie. Clearly, unequivocally wrong. I think, especially for some of the strategies we're going to talk about later, people offer these comments for a few different reasons. Sometimes people are genuinely trying to be helpful. They are well-meaning. It's just not useful advice. Sometimes people are not well-meaning, and it's not useful advice. But I think For a lot of people, when they say things that are unhelpful in response to someone who is suffering with a medical condition, it's telling you more about the person who's saying it than what they are saying. In particular, many of us at some deep level that we often do not examine like to believe that medical problems are the person's fault, because if it's their fault, we can't get it. This is obviously not true. This is obviously a toxic way of thinking. I have that ashtray there on the slides because how often have you been in this situation? I wager almost everyone has been in this situation. You're in a group of people, and somebody says, so-and-so just got diagnosed with lung cancer. What is the first thing the next person says? Are they a smoker? It does not matter if they were a smoker. We don't execute people for smoking. We don't wish lung cancer on smokers. Smokers don't deserve lung cancer. People ask that question because lung cancer is scary. And it is easier to believe that if you are not a smoker, you're safe. And it's easier to believe that that person brought it on themselves. That is not unique to lung cancer. That is 100% true of central disorders of hypersomnia. It is hard to watch people suffer with these diseases. It is scary. And I think for many people, when they say things that sound like they are blaming you for the problem that you did not choose, it's telling you that they are scared. And they know how hard this is for you, and they want to believe it can't happen to them. So I don't know if that helps, but I think that's where a lot of this comes from. The other "you are this way because" that I really wanted to try to tackle today is this: you are this way because it's all in your head. Whew, this is another one that's a real doozy. It's a problem on so many levels. First, it's just dismissive, right? It's people's way of saying, ugh, that's not real. It really shows, though, a number of different fallacies within it. So first of all, when someone says it's all in your head, what they're saying is that mental problems don't matter. That's definitely not true. If something is all in someone's head in the way we mean it colloquially, great, it's still a problem, it still needs to be treated, it still deserves compassion and medical care and all of those things. Second, it suggests there's like this actual real biological distinction between mental disorders and neurologic disorders, like somehow psychiatric diseases are not brain diseases. The brain and the mind are in the same organ. It's all the same brain doing all of these things. And so the idea that we might put things in buckets as being, oh, well, that's a mental problem, that's different, that's a neurologic problem, that's more important, really is not sustainable with what we understand about how the brain works. So whenever anyone says, people say it's all in my head, I say, yes, your head is where the brain is. So, but I thought, since we do have ways of looking at the brain, and the brain is in people's head, it is worth thinking about what do we know about the brain and idiopathic hypersomnia. And sadly, I had to give this one an ask again later, because the truth of it is not very much. But I think the truth of it is not very much yet. So there are a few studies of brain imaging in idiopathic hypersomnia. There are quite a number more in narcolepsy type 1. Not enough in that disorder either, but quite a bit more. There's a few in narcolepsy type 2. There's a few in Klein-Levin. Most of these disorders, we don't have nearly enough to know really about the neuroanatomy, functional or structural. What I'm showing you here is brain imaging. It's a kind of imaging called FDG PET, done on the left, it is Yves Devalier's group from France, and on the right, it's our data from here at Emory. On the left, it is green, is areas where the IH brain has more activity. On the right, it's the red are areas where the IH brain has more activity compared to controls. This is thought to reflect probably the fact that people with IH are having to work harder. Their brains are having to work harder to compensate for something that is happening. But even if you don't look at brain imaging a whole lot, you might get a sense that like where those green areas are and where those red areas are not the same areas. This is a problem, is that the few small studies we have in IH have not shown consistently the same thing because they had different populations and different imaging protocols and different thing, how long you took people off medicines and so on and so forth. So it's sort of hard to say, well, here's the overall theory regarding brain imaging in IH. This is from a group up in Montreal, Dr. Dang Vu's group, looking at a couple of different kinds of brain imaging in IH, and just to sort of make the point that we have a few groups looking at this, but they're all pretty small, and they're all getting kind of different results. One of the things that I'm really excited about is that there is now an international consortium where the idea is to take people doing any kind of brain imaging in any of the central disorders of hypersomnia and make a consortium where we can all pool our data and use that to all look at the same question at the same time across our different samples. And so instead of having like the group in Montreal looking at 15 people with IH, and we have 16 people with IH, and another group has 10 people with IH, we could pool all of the IH data and all of the control data to have much more scientific power to understand what's happening in the brain. And so shout out to the Hypersomnia Foundation for supporting that consortium in its early days getting up off the ground. Okay, for the rest of my talk, I'm going to pivot to the you just need tos, the strategies that people are being told by other people, and is there any truth behind them? What do we know about those strategies? And again, sometimes I think these are well-meaning, sometimes I think these are not well-meaning, but my response to all of that is at least to understand what the data is so we know, what is worth holding on to and what is worth getting rid of. So the first thing before I say any of the strategies is, of course, you don't just need to do anything. There is not an easy answer to any of these disorders. If there were an easy answer to any of these disorders, someone in this room would have found it already. Many people in the room would have hit on it, right? If there was an easy solution to IH, it would have been figured out. And so much as I think it would be great if there were a single easy solution that would fix all of this, we all know that's not true. There's not going to be one thing that someone suggests is going to fix you that's going to fix you. Okay, so I'm going to look at a couple of different tools as we go through this part of the talk. This was an online study by Jason Ong and several of his colleagues. It was an online survey. It was through a patient organization, of a narcolepsy patient organization, and they asked people with narcolepsy and IH to fill out this survey, and I'm only going to look at the IH data. And so there were 129 survey respondents who said they had IH, and they were pretty typical of the kind of people who participate in IH studies, meaning mostly women, mostly in their 30s. Adolescents get IH, adolescents get narcolepsy, adolescents get Klein-Levin, and they may respond to some of these things differently. And so I didn't want to leave out the adolescents from this talk. I could not find any data on adolescents with IH and how they do with some of these strategies. I don't believe those are out there yet. So I'm pulling from this study particularly of people with narcolepsy, type 1 or type 2, ages 12 to 22. They actually only got 35 adolescents themselves to fill out the survey, but 116 parents of adolescents with narcolepsy filled out the survey. So yes, parents in the room understand and appreciate this. So when I show you this study, it's adolescents with narcolepsy. Okay, what about exercise? I think people seem to hear this a lot. You need to exercise more. Well, what do we know from the survey? So from the survey looking at adults with IH, they asked people, have you tried this to manage your IH symptoms? And for exercise generally, about 58% of people with IH had tried it. For yoga specifically, same percentage. And then for each strategy, they said, of the people who tried it, on a 0 to 10 scale, where 0 was not at all helpful and 10 was great, how helpful was it? So the IH people found an average benefit of 2.2 points on a 10-point scale for exercise and a whopping 1.3 points on a 10-point scale of yoga. That's disappointing, right? Like, that's not a really robust benefit. It does suggest there might be some benefit, though, and particularly for a category like exercise, it's pretty big. You might imagine there's a way to winnow that down that might be helpful, but certainly not an easy answer where just exercising more dramatically helped people. The numbers are, I think, kind of surprisingly different in the narcolepsy group. So this is, again, the adolescents and the narcolepsy group. Most of the adolescents had tried exercise. Not a lot of adolescents doing Tai Chi or yoga, apparently. Hadn't tried that a lot. But in the exercise group, 78% of the adolescents thought that exercise helped with their narcolepsy symptoms. Their parents actually didn't perceive it to be as helpful, but still more than half of the parents thought it helped their adolescents. And similar numbers for the small group that was doing yoga or Tai Chi. So a little bit rosier, maybe, than the IH data. Is that because of how they asked the question? Is that because really it's a difference between narcolepsy and IH? I think that's probably less likely. Is it an adolescent versus an adult? Don't know. So maybe a glimmer that at least some people could benefit from at least some kinds of exercise. What do we know? Like, do we have a good randomized trial of exercise in IH or narcolepsy? Nope. Do we have randomized trials of exercise in other disorders that cause sleepiness? Yes. So in obstructive sleep apnea, which is a breathing problem in sleep that causes a lot of sleepiness, for some people, there have been lots and lots of studies about how to treat that. What you are looking at here is a study that took 64 other studies and their results that looked at any treatment for sleep apnea and then kind of ranked them in terms of how helpful each one was. And the exercise was one of the treatments that they looked at. Not many of the studies were about exercise, but a few of them were. And basically they found that the Epworth, so the Epworth scale I'm going to talk about probably a lot in this talk. This is the one everybody has done in clinic. It's the how likely are you to doze off in different situations, watching TV, reading a book, sitting quietly after lunch without alcohol, yada, yada, yada. 0 to 24, higher scores are worse. Exercise in sleep apnea improves the Epworth about 3, which that's actually in the same ballpark as a lot of our medications, a little bit lower than the average benefit of a medication, but at least in that disorder that causes sleepiness, exercise is helpful for sleepiness. And in people who don't have sleep disorders, both in teens and adolescents, a number of trials have been done to look at what exercise does to sleepiness in general, to people who aren't particularly sleepy to start with, although the general population is probably sleepier than we would like. And you can see there on the far column, Epworth changes, modest, but the Epworth moves and generally moves more than the control conditions. And so some suggestion that exercise is generally good for sleepiness. Exercise is also good for many, many other chronic diseases, both their prevention and their treatment. And so it's not all that outlandish to think that whatever IH turns out to be, whatever narcolepsy type 2 turns out to be, exercise might be good for it. But we really just don't know. I think a really important caution with exercise is that many people find exercise helpful. Many people feel better after they exercise. We don't have a ton of ways to increase the number of spoons that people have, but many people find that exercise does give them more spoons. For some people, that is definitely not true. So in chronic fatigue syndrome, myalgic encephalitis, and now in long COVID as well, there is a phenomenon called post-exertional symptom exacerbation or post-exertional malaise, where sustained either physical or cognitive exertion makes people's symptoms rebound and be much, much worse. So these are people who exercise, and then instead of just being tired because they exercised and feeling good, are much worse than their usual baseline, can't get out of bed, have horrible, horrible rebound of their symptoms because of it. When one of our medical students looked at our IH and narcolepsy type 2 and sleepy population generally to see how many of them met criteria for chronic fatigue, including this post-exertional malaise, 20% of our sleepy people also meet criteria for chronic fatigue, including this post-exertional malaise. So I think we need more data. I think that about everything in this talk. I think that about everything in IH generally, but we don't know yet what exercise, how much exercise, who should exercise, does exercise help? There's a lot of unknown questions. I would say in the meantime, it is very individual. So some people can exercise and it helps, but watch out. Watch what happens after you exercise. If you get this rebound worsening, it needs some careful modifications. Pushing yourself to the point of post-exertional worsening is not helpful. Okay, so I'm giving you just need to exercise more, and it's complicated. Okay, you just need to eat better. What did the survey say? So in the IH survey, about 40% of the adults with IH had tried diet changes to help with their IH. That 0 to 10 scale, where 10 was really, really helpful and 0 was not at all helpful, 1.9. So maybe there's some signal in there. Certainly it is not obvious and certainly it is not robust. Part of the problem with that is, I mentioned earlier there's lots of kinds of, why will my slides not advance? Lots of kinds of exercise. There's lots and lots and lots of different kinds of dietary changes you might make. And so just asking people about diet, while it's an important data point, doesn't give us enough granularity to really know what might or might not be helpful. Just like we saw in the exercise data in the adolescents with narcolepsy, they tended to find diet changes pretty helpful too, and their parents a little less enthusiastic, but still generally thought the diet changes were helpful. Again, we don't know what the dietary changes were. No data in IH yet. There is an old study in people with narcolepsy. They could have type 1 or type 2. They had to not be underweight. There were only 9 people, 8 of them were men. And they had people go on the Atkins diet. So old school, low carb diet. And they literally gave them the Atkins diet book from the 70s or whenever that was from, and followed them for 8 weeks. And in the 8 weeks, one of the 9 people dropped out because it's a hard diet to follow. And then for the remaining 8 people, the Epworth did not change. So that how likely are you to doze off totally did not get better in the Atkins diet for 8 weeks. Excuse me. They also looked at the narcolepsy symptom scale, though, which had sleep attacks and sleepiness questions, and they did see a modest benefit on sleepiness with that diet change. I don't think this is nearly enough to go tell people to go out and change to the Atkins diet. It has some nutritional concerns, and we don't really know even from this that it works. If it does work, it was only a really modest benefit. But that's the data we have. Again, what in the general population do we know about the relationship between diet and sleepiness? In observational studies, people who eat more processed foods, highly processed foods, tend to be sleepier. People who follow a Mediterranean diet, so lots of fresh produce, lots of whole grains, meat considered as sort of a garnish rather than a main part of the diet. People who are on Mediterranean diets are less sleepy. What do we know about diet and sleepiness in the general population in controlled trials? It's not exactly what we just saw from the observational studies, meaning that the observational studies suggest people who follow a Mediterranean diet are less sleepy. Here, there was a study where they tested that, and it didn't work to decrease sleepiness. There is a study suggesting the ketogenic diet, which is low carb and very, 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 very hard to follow, is associated with less sleepiness and better cognitive testing. And then low-calorie diets maybe reduce sleepiness in the general population. So, I don't know. I would say right now, ask me again later. I think it's possible there might be a dietary change that would be helpful for sleepiness. We sort of see hints throughout all of those studies that I showed you that maybe there's a role of diet, but the problem is they don't all point in the same direction. All of those studies pointed in different directions. And so right now we just don't know enough to say like, oh, yeah, maybe try a diet and see if it's helpful, because we don't even know what diet to try and see if it's helpful. So I don't know. Right now, you just need to eat better, I don't think is the answer. Maybe someday we will know more. All right, you just need to get treated for depression. This one came up on the social media posts like a lot. This one I think is tricky. And I think it's tricky because many people are told you just need to get treated for depression in a very dismissive way. It's a way of saying, oh, well, you don't really have a sleep problem. It's just depression. It's not really a big deal. That's obviously not true. But there are some really important overlaps between IH symptoms and depression symptoms and IH and depression. And so I think we shouldn't throw out the importance of depression just because many people have had the experience of being dismissed by doctors who say, oh, it's just depression. It's not a problem that I should have to deal with. So sleepiness is a really, really common symptom of depression, particularly in younger people. Up to 75% of younger adults with depression have excessive daytime sleepiness. And for some people, the sleepiness comes before the mood symptoms, sort of chronologically in time. Some people with depression have long sleep durations. So both if you ask people with depression how long they sleep, but also if you measure them in the sleep lab. David Plant has done some great work. People with depression, there's a subgroup of people who sleep a lot. And if you make people with depression undergo the multiple sleep latency test, that horrible nap test that we do to diagnose IH, about a quarter of people with depression meet the MSLT criteria for idiopathic hypersomnia. And one of the really common symptoms of depression is difficulty waking up in the morning. So people with depression sleep a lot, have trouble waking up, are really sleepy, and sometimes have an abnormal MSLT. That really sounds a lot like IH, right? Depression and IH are definitely different, but there is a lot of symptom overlap in common. I think there's lots of reasons why there could be an overlap. I think there's lots of reasons why we see depression and IH and depression and narcolepsy happen together so often. Here's sort of 4 possibilities. I think all of these probably happen depending on the person. So I think it is very, very real that, that people with bad sleepiness disorders sometimes get depressed because these are really hard diseases. These are diseases that impact every aspect of daily functioning, every aspect of relationships. It's not surprising that some people dealing with these bad sleepiness disorders just develop a reactive depression because of that. But also there are people who clearly have depression symptoms first, and then as part of their depression, they develop some sleepiness. I think it's plausible there's some sort of common trigger we haven't identified yet that causes people to have both depression and sleepiness. And then it's also certainly possible, it's not like the brain can only have one disease at a time. It might just be that some people have 2 different diseases happening in the same brain at the same time. So really, I think the important question is, does treating depression help if you have narcolepsy or if you have IH? So I think the answer is yes, and potentially it can help in a couple of ways. I think potentially it can help with a lot of the overlapping symptoms. So fatigue, sleep inertia, brain fog, all of these things are common in depression, and depression treatment can help with all of those things. But also the non-overlapping symptoms, the symptoms that you have with depression that you don't have with IH, like sadness and guilt and anhedonia, not enjoying things, those are hard. Those are bad symptoms. And thank you. I'm going to run out of water up here. Those are bad symptoms. And having those symptoms treated, even if it doesn't fix the IH, still makes those bad symptoms go away, or at least be less severe. And so I think, I talk to a lot of people with IH and narcolepsy, and some people have their hypersomnia disorder, and that's what they're dealing with. And some people have their hypersomnia disorder and depression. Not here to rank the degree of difficulty of anybody's disease, but you might as well treat all of the things that are making life harder and are impairing quality of life. And so I don't think we should ever tell anyone you should just get treated for depression. I don't think we as healthcare workers should see somebody who is sleepy and say, oh, you're a woman, you must be depressed. But I do think that if you have depression, it's worth treating because depression is also bad. What about a CPAP machine? So sleep apnea, breathing disorder where people stop breathing repeatedly overnight when they're asleep. Most people don't know that it is happening because they're asleep. Spouses, bed partners sometimes know, but often do not know. Sleep apnea is incredibly common in the general population. It is a very, very, very common cause of excessive sleepiness in the general population. In fact, if somebody walks in the door of a sleep center and they say they're sleepy, they're much more likely to have sleep apnea than they are to have IH or narcolepsy, just based on how common the disorders are. And there can be overlap between the way the symptoms of sleep apnea present and the way the symptoms of IH and narcolepsy present, beyond the fact that they're just sleepiness in both disorders. Sometimes people with sleep apnea will say, like, I slept for 10 hours and I don't feel any better from it. I had to keep sleeping because I wasn't refreshed from sleep. Cognitive dysfunction, which is a big problem, of course, for people with IH and narcolepsy, can happen in people with sleep apnea as well. But despite the fact that they have similar sort of symptoms, the treatments are completely different. So there's lots of ways to treat sleep apnea. It's a whole nother talk. I think many people think of a CPAP, a continuous positive airway pressure. That's what you're looking at in the top left-hand corner. Machine that blows air through one of the masks in the top row or 1,000 different other masks to hold the airway open so people can breathe when they're asleep. But there's lots of other treatments. There's a mouthpiece people can wear. There's a nerve stimulator that's implantable. Sometimes people can just treat their sleep apnea by not sleeping on their back. We are not very far away from medications to treat sleep apnea, although we're not quite there yet. So I treat people for sleep apnea all the time. I think sleep apnea treatment is important. It helps with sleepiness and other related symptoms. But in order to get to a diagnosis of IH or narcolepsy, sleep apnea should have already been evaluated. It is part of the process of getting to the diagnosis of a central disorder of hypersomnolence to evaluate for sleep apnea. If sleep apnea is there, it should be totally treated and the symptoms are still there, and then you get an evaluation for IH or narcolepsy. And so I think most people know they've already had this evaluated, but when someone says, oh, you're sleepy, just use a CPAP, like if you got to an IH or narcolepsy diagnosis, by definition, it wasn't just sleep apnea. That wasn't the cause of the symptoms. So, I don't know, I'm giving this one an it's complicated. If you have IH or narcolepsy and sleep apnea, yes, definitely, we like people to breathe, and so treating the sleep apnea is helpful, but if you have two disorders, you're going to need to treat both disorders, not just one of them, to get optimal outcomes. All right, you just need to stop taking this medicine. You just need to change your medications. I was a little surprised that that one showed up on the social media the way that it did, but apparently that's advice people are getting. That one I think is reasonable advice in the big picture sense that many medications cause sleepiness. So generally speaking, sedating medications don't give someone the whole picture of IH or the whole picture of narcolepsy. Generally speaking, if people are on sedating medications, that contributes to the symptom burden rather than causing it completely. But I have seen patients who came in to see me and looked just like they had IH, and we got them off of one medication and their symptoms went away. I haven't seen very many of those, but I have seen that happen. There are some medications out there that are pretty sedating. What you're looking at in the figure on the left is just an alphabetized list of commonly used antidepressants. And where the box is on one side of the number one line or the other is how sedating it is relative to placebo. So you can see on the less than one side, there is exactly one medication, which is bupropion. It is less sedating than placebo. Every other antidepressant was on the more sedating than placebo side, some of them statistically significant and some not, but in general, antidepressants have a tendency to be sedating, but some are more sedating than others. And so sometimes what we do is not say, oh, well, just don't be on an antidepressant, because that's often not the right answer. Anything that starts with a just do this or don't do that is often not a great answer. But sometimes what we do is take someone from a more sedating antidepressant to a less sedating antidepressant. It is not just the antidepressants. There's lots of anti-seizure medicines that are sedating. Many cardiac medicines are sedating, which can be a surprise for people. So blood pressure medicines like beta blockers, some of the medications to control abnormal heart rhythms are pretty sedating. Pain medicines, muscle relaxants, other psychiatric medications other than antidepressants. And then, of course, things like sleeping pills. Sometimes people are surprised at quite how much carryover they can have into the morning. So again, this is the thing that before you got a diagnosis of IH or narcolepsy, your sleep doctor should have evaluated and considered. Sometimes it's a thing that we can definitely rule out. We can say, well, we've got to get you off this medicine and see if your sleepiness goes away. Sometimes there's medicines we can't stop and we try to change to something less sedating. But it's at least on the radar for anyone who has an IH or narcolepsy diagnosis. And so it's never simple enough to just say, well, just change your medicines. But I think there really is a grain of truth to this, and that we know that many medicines can be making the problem worse. This one was all over the social media list, which is you just need to go to bed earlier. This is an area of very active debate in the IH medical literature right now, because there's a number of studies that suggest that people with IH tend to be night owls. And then there's a group of people who say, oh no, if you're a night owl, it's a totally different problem. It's not IH. But many IH studies suggest that a big group of people with IH are night owls, so it's easier to fall asleep a little bit later, sleep a lot later. Why does it matter if people with IH are night owls? When you are biologically a night owl, it's because your internal clock is shifted later. And so your brain actually thinks that nighttime is several hours shifted to when the moon says it is nighttime. And so for people with really shifted circadian rhythms, when they're trying to wake up in the morning because their alarm has gone off and said it's morning, their brain still thinks it's the middle of the night. And so it's much harder to wake up. And so it's hard for people who are night owls to wake up in the morning. This is one reason that sleep inertia may be problematic in people with IH. It's not the whole reason, but for some people, this sort of night owl tendency can worsen sleep inertia. I think the other problem that can happen with being a night owl in IH that I hear from people a lot is, they struggle to wake up, they struggle all day, take all their medicines and so on, and then finally have a period of feeling relatively okay, but it's at like 10 o'clock at night. And that's just a really bad time with their kids' schedules and their spouses' schedules. It's sort of the feeling good peak of the day is not at a good time. And so I think for some people with IH, we try to target the night owl tendency. We try to change the timing of when their body thinks it is daytime and nighttime. And for some people, we leave it alone. It really depends on the context of the individual person. But when we try to change someone's circadian rhythm, we don't do it by telling them to just go to bed earlier. That actually doesn't really work. There's a big difference between going to bed and falling asleep. And so for people whose underlying biological rhythm is shifted, if they just get to bed earlier, they just stay awake in bed longer before they fall asleep. And so if we're trying to shift their circadian rhythm, we actually have to do this with things like timed melatonin and timed light exposure and sometimes timed eating. And so it is certainly not enough to just go to bed earlier. This was on there a lot, which was both the idea that you should sleep more and the idea that you should sleep less. I don't know how both of those things are supposed to be true, but presumably it's different people offering those two bits of advice. This is one where I really wish I had a better answer. There is an idea in the Diagnostic Bible for Sleep Disorders, so our diagnostic manual that lists all the sleep disorders and tells us how to diagnose IH and what's the difference between NT2 and IH and all of that. There's this section in the back, and it's called Isolated Symptoms and Normal Variants. And in the normal variants section, they have this thing called long sleeper. They basically say some people just need more sleep. Some people, they just need more sleep, and if they get more sleep, they will feel fine during the day. So if you need to sleep 11 hours and then you wake up and you feel fine, it's not idiopathic hypersomnia, it's long sleeper. I use the diagnostic manual. I do a lot of work with the organization that writes the manual. I don't mean to pick on the manual. I really disagree with this point. In the sense that I think if you have to sleep 11 hours, you have a problem. It's really hard to sleep 11 hours and then have enough hours left to do life, because that's how math works. I think the point that different people will have a different amount of sleep that may impact how they feel the next day is probably true. It may be true, well, it's definitely true in the general population level. It may or may not be true in IH. I definitely have people tell me it does not matter if I sleep 6 hours or 8 hours or 12 hours. I feel the same terrible. And so how much should I sleep? I don't know the answer to that. But I also have patients who say, you know, if I sleep 8 hours, it's a little easier to wake up than if I sleep 10. Or vice versa. I just do better, even though I still have IH, even though I still feel bad during the day, I just do better if I sleep 10 than if I sleep 8. So there's no data on this question. There doesn't seem to be any way to predict what that is going to be for individual people. But I think it's worth paying attention on an individual level to does it matter? Many people, it doesn't matter how many hours they sleep, they're going to feel the same way. But for some people, they can actually find a duration that's a little bit more helpful to hold to consistently. And so then I think that is worth looking for. So I gave that one an Ask Me Again later, because I would believe there might be data in the future that would help us tailor that on an individual basis. I will say, as a just sort of general statement, don't forget that sleep is important for human health. So I think what happens sometimes to people who have narcolepsy and IH is they feel so bad after they sleep. It's like, why should I bother sleeping? For those of us without sleep disorders, we know that we have to sleep because if we don't sleep, we feel sleepy. But if you feel sleepy all the time, you sort of lose that reinforcement for like, why am I bothering to sleep in the first place? Sleep is still really important, even if you don't feel better after you do it. It's really important for functioning of human bodies. So what you were looking at here is from a scientific consensus panel where they got together and they looked at hundreds of studies about sleep duration in the general population. They asked people, how long did you sleep? And across these different domains of health, they looked at what's the evidence that there's a right amount of time to sleep for the best health outcomes. And basically, it was green, all the data pointed to this being the right amount of sleep to support that domain. And you can see a pretty consistent band of green at the 7 to 9 hours. And so I don't think that people with IH should be on purpose shortening their sleep if they feel better with more sleep. I worry more about the shorter end. I think, especially with medications and with how hard it is to find good hours in the day, I think sometimes people with IH and narcolepsy end up shortening their sleep too much, and that can be a problem. So that 7 really is important, I think. For most people with sleep disorders, 8 is a better bottom range goal to have in mind. All of that is for adults. Kids need a lot more sleep. I would highlight the 13 to 18-year-old bar there, which is 8 to 10 hours. This is a problem in probably the world, but certainly in the country. I don't think our teens are getting 8 to 10 hours, but that is optimal for that age group. Naps, you just need to take naps. This one came up a lot on the social media as well. This one I think we already know. We don't have great scientific data, but we sort of know from the experience that everyone has shared. Naps for people with IH tend not to be that helpful. So 81% of people with IH reported that they were taking naps, but it only got a 2.7 out of 10 in terms of how helpful it was. I think the problem with naps for most people with IH is they don't feel better after they wake up from them. So many people can't avoid them. They have to take them, but they may not be that helpful. Sometimes they are, but as a general rule, not found to be super helpful in IH. What about having a regular sleep schedule? I was a little surprised to see that 75% of people with IH were trying this strategy, and it got a 3 out of 10. Now, 3 out of 10 is not that great, right? But that's actually higher than anything else I've shown you. The problem is from this study, it's not clear when that scheduled night was and how people scheduled that. If I had to guess, I would say consistency is better than inconsistency. We certainly know that across sleep disorders generally, and sleep more broadly. So having some sort of pattern is helpful, but again, a pretty modest benefit on the 0 to 10 scale. You just need to get your thyroid checked. I hate the word idiopathic in the title of idiopathic hypersomnia, but one of the things that it means is that, like, before you got the diagnosis, the person who diagnosed you should have ruled out other causes for your sleepiness. We don't, as a field, as sleep doctors, have any unified agreement on what all of the things that should be ruled out are. But I think everybody thinks that thyroid disease should be ruled out as the whole driver of sleepiness. I think iron deficiency should definitely be ruled out. Iron deficiency is extraordinarily common in premenopausal women, and certainly can cause sleepiness and fatigue and brain fog and the symptoms we all know so well. Note that this is not just testing for anemia. It is routine to test for anemia when you go to your primary care doctor. It is not routine to test for iron deficiency, even if they might say they're checking your iron. And then B12 sometimes. But other than that, there's still an open question about what you should get tested. I think we all would love to be in a future state where we knew what IH was, where we knew what NT2 was, and we had a biomarker, we had a blood test, or even a spinal fluid test, or any kind of test that we could do and just say, oh, yes, this is diagnostic. You have IH, you have narcolepsy type 2. We know what causes it, and look, you have it. We are obviously a ways away from that, but I gave this one an ask me again later because eventually we're going to figure out what IH is and then be able to diagnose it better. You just need to take this supplement. Seems to be advice that people get a lot. Sometimes it comes from people selling supplements, but sometimes it just comes from, I tried this supplement and it made me feel better, so you should try this supplement. Maybe it'll make you feel better. I am certainly open to the idea that a supplement might be helpful, just like I'm open to the idea that lots of prescription medicines might be helpful. We like to test things to know if they are helpful or not. And so I think often we don't have the information we need to know whether someone should try a supplement. I think one of the things that's important to know about supplements is they are not regulated like medications. They are closer to foods in terms of how they're regulated. And so just because it says it has something in it doesn't mean it has that in it. Doesn't mean it doesn't have other things in it. So I am showing here in the table or in the illustration a study of melatonins. And I picked melatonin because we use it a lot for different sleep disorders, including sometimes for IH. So they got 31 different brands of melatonin, and then they measured them to see how much melatonin they had in them. And the worst one had 83% less melatonin in it than the label said. And then on the other end, the worst one had 478% more melatonin in it than it said on the label. Yeah, that's a big range, right? And they looked at serotonin content. Serotonin wasn't listed as an ingredient in any of them, but it's related to melatonin. 1 in 4 of the melatonin supplements also contain serotonin. So this is just an example. I don't mean to pick on melatonin, but the sleep data are best for melatonin. The point is, it may contain things that are not on the label. It may contain more or less of what it says it contains than what it does. So is there a role for supplements? Sure. If you're iron deficient, please take an iron supplement. So we want to replace things that are deficient. When there's data, like there's good data for melatonin and some other sleep disorders, so we absolutely use it in those cases. What worries me is the idea that I think some people think supplements are just safer than prescription medications. And to that I would say maybe, but until we have data, we don't know that. It's worth keeping in mind that if it is potent enough to help you, it is potent enough to hurt you. So it's always about balancing risks. So ask again later about supplements. And with that, I think I left myself like 60 seconds for questions, but I'd be happy to take some questions.
Thank you so much, Dr. Trotti. From our online viewers, we do have one person who is commenting about depression diagnoses, and if you have that comorbidity, it's difficult to get medical providers to take your IH seriously. Do you have any guidance or recommendations or suggestions around that?
Yeah, I think that's so tough, and I think that question really highlights the bias in the healthcare world that healthcare providers tend to have this crazy, it's all in your head mindset of like, well, if it's depression, it doesn't matter. I don't know how to fix that in healthcare. I wish I did. It's obviously not true. But I think it can absolutely be hard to find a provider who still takes your IH seriously if you have a mood disorder diagnosis. I really think team healthcare is the way to go. I think talking to people's psychiatrists or therapists or rheumatologists or other providers for their key other disorders is really helpful. And so it's hard to do. Doctors can't do that, every visit on every patient. But I think if you can find someone who sort of has a team mentality and is willing to sort of go across specialties to think about what your other providers are doing, that can be helpful.
Howdy, Claudia here. I've heard talk about this increasing study of the gut-brain connection, so whatever's happening with the flora in our gut directly affecting what's going on with our brain, the things that we eat can change these things. And I've seen some studies talking about how, at least for narcolepsy, maybe there's a bit of something there for like diet and whatnot, and I saw you mention that. Are there any studies that are directly talking about sleep disorders and the gut-brain connection, and has anything come up regarding, I believe they're called FODMAPs, like alcohol, sugars, carbs, things that people who have GI issues like IBS have harder trouble digesting? My guess is that for people like us, it takes more energy to do anything, and that includes digesting. So what we got going on there? That's all I really wanted to know.
Yeah, no, great question.
And to piggyback on that, somebody online was also asking about raw food diets and if there's any evidence around that.
Yeah, so, well, then I'm going to take those in reverse order. Raw food diet, evidence, no. Not yet. So the gut-brain axis, I think, is a really exciting area. There are studies not within central disorders of hypersomnolence, but just in people who have bad sleep quality at night and are sleepy, that some of that sleepiness may be mediated by changes in the microbiome. There's a little bit of data, as you alluded to, in narcolepsy type 1, that if you take people with narcolepsy type 1 and you take people who are not sleepy and you look at the composition of the bacteria in their gut, sort of all the different species and the relative proportions, it's not the same. What's cause, what's effect, we don't know yet. It feels like you were a plant for my study with that question, although you were not. We're doing a study to look at whether changes in the microbiome relate to sleepiness in IH and narcolepsy, particularly for people who are treated with the medication clarithromycin, which we sometimes use for sleepiness, which is an antibiotic. And so we are looking at the mechanisms of it, one of which might be changes in the microbiome that then result in changes in sleepiness. And so we're still recruiting for that study, if anyone has not heard about that. Sleep.research at emory.edu. But we are not the only ones looking at the microbiome and sleepiness. And so I think as those studies start to come out, we'll have a little bit of better data to answer that question. So I would say right now, there's sort of some hints, but nothing definitive at all. I'm certainly not ready to conclude that it is or is not related.
Thank you so much, Dr. Trotti. Unfortunately, we are out of time. I know we have a lot more questions for Dr. Trotti, but we appreciate you, Dr. Trotti, and she will be on an upcoming panel at 4:30, so save your question for then.